and welcome to the Mommy and Baby Show. I'm your host, Masi Tetu, and this is the very first episode of season 1 of the show. And we are so excited to finally be bringing you a whole season whereby we'll be looking at pregnancy all up until when you deliver your child. And also more to that, we are excited because we have a partnership with RFH Healthcare. So you are sure we'll be bringing you the correct information, factual information, tried and tested. So do not move, sit back, and you can be sure that this is where you get everything that you require. So for this very first episode, we'll be discussing pregnancy. And to take us through this is none other than gynecologist Dr. Jonathan. Karibu sana to the show.
Thank you so much.
So just before we kick off the questions, please just let us know a little bit more about you.
Yes, I'm Dr. Jonathan Mashala. I'm a gynecologist, resident gynecologist for RFH. I think that is enough.
Welcome to the show.
Thank you.
Really appreciate having you here and giving us your time. So for my viewers who are watching back at home, yes, they just discovered that they were pregnant. Well, not discovered, but they just confirmed that they were pregnant. So what are the next steps that they should take immediately after confirmation of pregnancy?
Yes, confirmation of pregnancy is the first individual, means that you can miss your period. But missing your period is not a confirmatory test or knowledge you should have. Mm-hmm. There's what you call pregnant tests, which is a confirmatory test. Means that when you miss your period, you can have some symptoms of nausea, vomiting, but those symptoms, they are not also specific. You need to do a pregnant test. That is we call confirmatory test. After you have confirmed that you are pregnant, nowadays people, they do it home, but we don't rely on what patient has done. But when you come to we need to come to the hospital, and the hospital, you are going to repeat the same test to confirm, because some tests the patient they are buying, they can buy it has expired. Means that the patient feel I'm pregnant when she's not pregnant. Now we need to confirm in the hospital.
Yes.
That is because the hospital, we check the expiring date of that test, that kit, and we are sure that what we are doing is the right way to do it. But people who are doing home, we don't discourage them. They can still do, but they should not also be bothered when they come to the hospital and we repeat the test.
Yes.
And after repeating the test, according to WHO, you can start your antenatal clinic from 10 weeks to 12 weeks. You need to start your antenatal clinic. And when you come to start your antenatal clinic, there's something we call antenatal profile. There are some tests we need to do. We need to know your blood group. We need to do your HIV status. We need to know level of blood in your body. We call it hemoglobin. It will give us idea, because anemia is one of the cause of miscarriage. A lot of things happen because you'll have even IUDR, what you call intrauterine growth restriction, because of anemia. Means the baby will not get much of ingredient which are coming from the mother for the growth. And we need to check. We need to check random blood sugar to make sure that, because you can be diabetic, and you find that the random blood sugar is after eating, and you find that it's so high, it can attract us. Means that I'm dealing with a diabetic patient, and we can dig more to go to your family to find out your family. What is their story? Mother is diabetic, father diabetic, all those kind of things. And we need to do also syphilis test, because we know as long as you are sexually active, you can get syphilis, which is sexually transmitted, and it has also impact on the baby. Baby can develop or can be affected by that infection. We can also HIV also affected the baby. Means that once we have HIV test, we tell ourselves we are dealing with HIV negative or HIV positive. If it's a positive, there are some medication we need to prevent for the child not to have that HIV.
Yes.
And we can also do hepatitis B antigen, which we do because it can also affect the baby. If it's positive, there's a treatment. If it's negative, we can see what to do next. But if your hepatitis B is positive, is not straight away you go and give. There are some tests need to be done for us to confirm if that infection is active, is not active, and that from then we decide which way of management we should go with. Those are the tests we do. Sometimes we add also malaria, because malaria also contribute to low weight baby, this and that. And we know some areas, like if you are in Kisumu where there's malaria, you need to do that test of malaria to know. It can also lead to miscarriage. And those are the tests we do. And you need to start going for antenatal clinic. Yes. Means that when it's still the beginning, they start giving 1 month. Every 1 month you go. And in first trimester, you need to do also the scan. The scan gives us the growth of the baby, location, the pregnancy is in a good place, and it's developing. Because sometimes we have done a pregnant test that is positive, and we believe that you are pregnant now because it's called confirmatory test. But you can develop what you call an embryonic pregnancy, which is just the sac and there's a fluid inside, but there's no embryo. Now, if you do not do the scan in the first trimester, you might not know what is happening. Yeah. But as long as it's not a good pregnancy, because this is an embryonic, means it's not good pregnancy. You might see spotting, this and that. But those spotting, they are not specific only for an embryonic pregnancy. They can happen even in normal pregnancy. Now, that's why the first scan is also going to help us to see, no, embryo is developing. They will tell you about fetal pole, they will tell you about yolk sac, all those things, they are there. And you can see when you come to start your clinic by 10 weeks, we should have the heartbeat is there. And second trimester, what is important is to do another scan at 20 weeks to exclude all the malformation, because that is called anatomical scan, which is starting from head to toe. And they analyze everything, because by 3 months after fertilization has taken place, the baby is formed, human being is formed. Now the second trimester is now growth of her, all the part of the body, they are now growing. Yes. Now if there's a malformation, we will detect it by 20 weeks. There's a problem here. Now the question comes, if there's a malformation, is it compatible with life? Is not compatible with life. And that's how our management, that's why we find another malformation, we just ignore. We say, no, when the baby will be born, this will be done. Yes. But if you find it's not compatible with life, two gynecologists need to make a decision for termination of the pregnancy. That is the second trimester. Yes. And you notice also that every time you come to, once you have started your clinic, every time you come, we will start doing urinalysis. Why are we doing urinalysis in every appointment? Because we have two types of UTI, what you call urine tract infection. There's a symptomatic and asymptomatic. And when you have symptomatic, that's the time when you pass urine, you feel pain. When you pass urine, you feel itching. When you pass urine, instead of urine comes straight out, it takes time to come out. Means that there's infection. That one can lead you. Why am I having pain? Why am I having burning sensation? No, let me go and consult. But asymptomatic means that you don't feel anything, but you are passing urine well, but it's in the body. Now that one, it can immigrate to the kidney. And you develop what you call pyonephritis. Means you start feeling back pain, you are pregnant, and that back pain can lead you to miscarriage and lead you to preterm labor. That's why we need to start identifying. Now, when you do a urine test, and we found that you have leukocyte plus 2, it is represented by plus. That's what the lab gives you. Leukocyte is antibodies. They're supposed to be in urine, but below 5. Once it goes up above 5, now it's showing that there's infection. But the good test also to do when you are doing a urine test is to do culture. That's because culture is going to tell us which kind of microbe is causing that, and which kind of antibiotic, if you give, it will stop that UTI. But UTI in pregnancy, there's a mechanism which explaining is not sexually transmitted, because people think that when you are pregnant and you are still actively intimating with your partner, you get UTI. No, it's not that way, because urine, when you are pregnant, there's different hormones you are secreting. It's starting by ovary, and it will be shifted to placenta. When the placenta start forming by 4 weeks, it start forming, and that those hormones, they are going to reduce the movement of bladder. Means the bladder, which was contracting a lot to push the urine to empty the bladder, that contraction is going to be reduced by the hormones. And that means that the woman, pregnant woman, does not empty totally the urine in the bladder. And now there's a stars of urine. That stars takes time, it develop infection. That's why you hear us telling the pregnant woman, can you increase intake of water?
Oh yes, I've heard that.
And we are not saying that because increasing intake of water is going to heal UTI. No,
it's not.
Is to prevent you to develop. Now, out of hormones who are reducing the contraction, we have also the pressure of the uterus. When the uterus become big, is compressing the bladder. Means that the bladder is not going to contract more for urine to come out. That more you take the water, more you eliminate. And when you eliminate, the stars is always renewed in a few minutes. And that helps you to avoid the pregnancy. Now you'll start going to antenatal clinic, and you should respect that. Yes, because we are examining also when you come out of the test. We are examining to see, we are supposed to be at 20 weeks. Why the uterus is still at 14 weeks? That can tick us. No, there's something wrong.
There's something wrong.
But you are supposed to be in 20 weeks. Why are you in 38 weeks already? 36 weeks. You see, that can attract our attention. And we can think what next to do to identify what is going on here. You see? But unless you come to us, we will not know what is happening. That's why we have some cases where we have a missed abortion. The pregnancy stopped developing long time ago. But you are home, you say, no, I'm pregnant. And you reach 9 weeks, you don't see anything coming. 9 months, nothing's coming. Now, that's why antenatal clinic is very important.
Yes.
But also, when you reach the age of pregnancy, reach 28, there's ODTT, oral glucose tolerance test, which we do to identify, because during pregnancy, you can develop gestational diabetes, which can compromise the life of your baby. Now, we do also that test. Means that every step of pregnancy, there are specific things we need to exclude to make sure that we reach term in a smooth way, and your delivery should not have much problem. And the last trimester, we will also repeat the scan, because we need to know the weight of the baby, by the way. We need to know that this baby will be able to go. We need to identify again that there's not any malformation like hydrocephalus, all those malformation, that this patient, we are preparing her now for delivery, should not have a problem. Those are the globally what we do for antenatal clinic, and people, they need to know that antenatal clinic is the key for success of delivery. If you don't do your antenatal clinic in the proper way, you'll have a problem in delivery. And today you will notice that sometimes we have babies who are having cord around the neck 1 or 2, 3 times during delivery. It causes problem because it's going to tie on the neck of the baby. Or when the baby is inside, does not use the lungs to breathe, is getting oxygen through the cord. Now during delivery, because the cord might be short, and we will not have, the baby will not have that oxygen because it's tight. Means there's no blood coming to the baby, no oxygen. And that's where you found that she just delivered, the baby did not cry. They tried to restate the baby, they did not succeed. Now we need to identify those things on a good time.
Yeah.
That's what globally, what I can say about antenatal clinic.
Yes.
And you need to have discussion mostly for the first mothers with their gynecologist. What are we expecting from you to delivery? What are you supposed to expect from us?
Yes.
Means we need to discuss, make a plan of delivery. How are you going to deliver? How are you going to have as attitude in that? And what are we going to expect from you? And you, what are you supposed to expect from us? Yes. Those are discussions we need to have, mostly when we are 34, 35, 36 weeks, because we are going
towards the delivery.
The term of pregnancy and delivery can take, because from 37, if a delivery comes, normal delivery, you can go ahead.
Okay.
Without problem.
Oh, thank you so much. I have just 3 questions from what you've mentioned. You said the bladder does not express all the urine. So does that, and then you get to be given antibiotics. Are antibiotics safe for a pregnant woman?
Yes, we know that in pregnancy, there's so limited medication for pregnancy,
Yes.
pregnant women. But we have those antibiotics, because once UTI is diagnosed, it's not water you take is going to. I know people, they think
Keep
that let me
drinking
take
water.
more water,
Yes.
now infection goes. No, infection, please. If it's bacterial infection, you need antibiotic.
Regardless.
Yes, you need antibiotic, but please, today somebody can have his own gynecologist. Huh?
Yes.
You can have your own gynecologist. A gynecologist, they are, throughout their life is about woman.
Yes.
Means that when a gynecologist or obstetrician prescribe antibiotic, he should also know this antibiotic is allowed pregnancy, this one is not. It's like tetracycline. You can't prescribe in pregnancy. There are some medication which are not supposed to be prescribed, but there are some antibiotics who are supposed to be prescribed.
So the key thing is, do not self-medicate. If you see you have symptoms, do not go and buy something to treat yourself.
Personally, I tell my patient, you don't take anything without my permission. But now, that is a little bit tricky. You need to also be available. Huh? When your patient calls you, pick the call.
True.
Sometimes we don't pick the call, and
you're
she's
very, very busy. Yes, so they end up going to the pharmacy and buying. Yes. You're very busy.
Yeah.
So another thing you mentioned, because the bladder is not being expressed, we've been told that if you go to pee, you lean forward, that it will help the bladder to eliminate all the urine. Is that a myth or is that factual?
No, it's not. You see, that I think the people, but when the uterus is always big,
yes,
it's making pressure. But that pressure will not, you see, the bladder does not eliminate urine because you are compressing it. You see, there's a pressure which is in the bladder, 10 degree. Means that for your urine to come out, the pressure need to be above 10. You get the point? Now, if the pressure is not above 10, it will not. And the blood need to be full for that pressure to take place. It's not your compression making it like that. No. It is a physiological way of way the bladder is functioning, normal bladder. The way as we are here, we are not pregnant. How are you going to eliminate urine? You are going to eliminate the urine once it's above 10, and from then that pressure is above 10. That's when you have urge of passing urine.
Yes.
And it goes. Now, our problem is not to make a pressure. Well, when you bend up like that, what are you having to tell yourself that now I've pressed my bladder? You see, we don't have evidence on that.
No
but what else you are saying is that, you see, more you take water, the more you feel means your bladder is going to be often full. And then you eliminate.
Yes.
Even a small stars of urine which is remaining, it will be renewed.
Yes.
It will not stay for long. Because if you take for long, you develop
An
UTI.
infection.
Yeah, that's it.
So that's the reason. Okay. So once you started your ANC clinics, we told that you're going to be given supplements. Some women decide, I will not attend the clinic, but I will buy the supplements from a pharmacy. So what are those supplements, and is it okay to go and buy the supplements on your own?
You see, there are a lot of medication. Supplement, there are so many. We can't give the list of supplements because there are so many. I don't encourage a pregnant woman to buy any medication because you see, people are working in pharmacy, they are doing business, and they want
to sell,
to get money to move on. They can give you anything, but you see, before us to give you medication, we need to examine you. We need to go to your history. We need to know, I'm dealing with which kind of patient. We have the tests we have done. Based on my test I've done, I can tell this patient deserves this. Let me give an example. You are vomiting throughout, and you go to chemistry. They just, oh, you need supplement. They give you, there's plenty of omega. Omega is a fish product.
Yes.
And it gives more for vomiting. How can I put you are vomiting already, and I'm giving that. Means to make it worse.
Yes.
But it's good always to go through the doctor to give you supplement. Why are we even giving supplement? Because we have noticed that our patients who are pregnant, most of them, they don't eat much. Because normally, if you eat in proper way, you have your protein enough, you have your glucose enough, you have lipid enough, you don't need a supplement.
Oh.
But the problem is, are you eating? You see,
dependent.
Yes. Now you notice that you can find sometimes in 10 patients, only one can tell you, doc, hey, I'm eating very well. But as I know, I'm trying, hey, eating, hey, smell.
Yes.
You get those things.
Yes.
Now, medicine has done well to take your need in a calcium, to put in a small tablet for the day. Your need in this vitamin, in omega, in this and this and that, we put in the small tablet, you give you for that day.
Yes.
That's why I found that most of them is single dose. Yeah, it is summarized what you can get: folic acid, iron. This and that you need. They put in one tablet. It helps you to boost up your need for the day. That's why it is important for a patient to be on supplement.
But is it usually standard that every patient, every pregnant woman gets the folic and iron?
Yes.
Are they the two main?
Yes. The problem is why. The question is, why do you have to get folic and why do you give iron? What is their role in pregnancy? We don't give because we are happy to give, but we have a problem with eating. You can get those minerals through the food.
Yeah, from the diet.
But you are not eating much. Now, folic, by the way, is helping. There's different malformation, mostly in the first trimester. Folic is very important because you'll have a spinal bifida, you'll have, there are a lot of neural, I don't know, I don't know how to put it another way, defect. It means that you have the brain and
neural.
Defect. You have that, and folic can prevent. Iron is going to boost the blood for you to have a good, because if you have deficiency in iron, you go to anemia. You get to the point. Now we give those vitamins. It helps to boost formation of blood, formation of this. Like calcium, it helps you also to prevent blood pressure in pregnancy, and it helps also formation of the bones of the baby. It contributes. Those are the supplements we are giving, and it helps in that way.
Oh, I understand. You mentioned something about the complications that can come during early pregnancy. You mentioned about gestational diabetes. Can you maybe just tell us a few the most common ones that a pregnant woman should look out for, and these are the ones that she should seek urgent care if she sees them during her first trimester?
In first semester, when it comes about some disease which are related to the pregnancy, you see there's a lot of changes taking place during pregnancy. Once you become pregnant, it's like your brain increase the volume. When you become pregnant, your heart increase the volume. Means that if you have some malformation in your heart which were not manifested before pregnancy. During pregnancy, it
goes
pick up
up.
because your heart increased the volume, and your lungs, your kidney, and your liver, all those organs, they are affected by the pregnancy. And even the level or the volume of the blood increases during pregnancy. And from all those organs, the organ who had a defect can start manifesting some diseases. You can have cardiomyopathy, this and that from the beginning. But there are also like hypertension, preeclampsia. We talk about preeclampsia, eclampsia, means that those are the high blood pressure which are related to the pregnancy. And those high blood pressure, most of the time preeclampsia start from 20 weeks. But in some cases, it can also start earlier. Those ones, that's why when you come to antenatal clinic, we start checking your blood pressure often to identify. We do blood sugar to identify that you don't have diabetes in pregnancy, this and that. But sometimes we don't know our status before the pregnancy. And let's say I had blood pressure before the pregnancy. And when I get pregnancy, maybe blood pressure picks up most of the time in first trimester. When you find high blood pressure in first trimester, most of the time it is chronic hypertension which was unknown by the patient. Because you see, if you ask most of us here, the last time we check your blood pressure, somebody will tell you, I don't.
I can't remember.
You get the point. Huh? Now, when you have a problem, you come to the hospital. That's the time they check your blood pressure. Now, those kind of situation we are having chronic. You can also be diabetic, but you do not give more attention. At night, you wake up 4 times, 5 times. You go to pass urine. You are heavy. You have a lot of thirsty to drink a lot of water, but you never give attention to test. Why am I going too often to pass urine? Why am I drinking too much water? And when you did not give that attention to seek for help, you find yourself pregnant. And when you find yourself pregnant, when you come, we are starting by antenatal profile. You get, and you are 7 weeks, you are 10 weeks. I found your blood sugar 20, 30. Means this patient. Now we start digging your story. They say, hey, tell me, you don't go often before pregnancy. You were not waking up at night to pass urine. Oh, dog, even 10 times. Oh, you see this patient? 10 times. No, that is too much. This now we start asking. You do not have a headache. You do not have this. Oh, I remember there's one day I went and told me that my blood pressure was high, but they told me we can manage with the diet. You see, it gives you an idea how it is. Now, from then, we can take a good way of managing that kind of patient. Is a multidisciplinary management because I can diabetologist, I can look for that physician for blood pressure, chronic one. We can bring more consultant for you, and we start following you in that pregnancy until delivery. If you have a problem for heart, it's giving you legs start swelling, this and that, coughing, or different complication. Cardiologist needs to be there to tell us that, can I keep this pregnancy to term, or what can we do? No, doc, let's work together. I think we can manage. He's managing heart, I'm managing my pregnancy. And we move on. There's also complication when you are pregnant, which can happen, means that you are home, you feel the calf painful, and the leg is swelling, and this one is just good. That is, you need to rush to hospital. Why my calf is painful or my thigh is painful? You come because there's something called the DVT. Is deep vein thrombosis, which can happen in pregnancy. Why is it happening? Because status of pregnancy is hypercoagulation status. Means that every woman she's qualified to develop the clot in the vessels. You get the point, huh? Because it's a hypercoagulation which has taken place due to those hormones which are secreted by the pregnancy. Now it can happen that one of the patient has developed that. Once you feel that, any pain, it can be in the hip, It can be in the thighs or the calf, you need to rush, or it can be in the lungs. And your breathing starts changing. You don't have to delay home, because mostly when it's in the lungs, we don't call it DVT. We start calling it pulmonary embolism, because the clot has developed in the lung or the heart, and that one chance for dying very fast is there. You might not reach. Now, once you see that changes, please don't assume, don't tell yourself, no, let me observe. Rush first, let them do other tests to confirm if it is the one or it's not the one. Those are the complications can happen during pregnancy and some disease, and we take care of that. Now, once you have developed one of the condition like that, and the coming pregnancy after delivery, when you notice that you are pregnant, tell the doctor who's following you that, hey, my past was this, I had blood pressure, I had diabetes, I have this. It's very important.
Very important. With the DVT, because I've heard about it before, you've developed it due to that pregnancy. Is it manageable? And does that mean, will it end with pregnancy ending, or will you treat it and it will end before my 9 months?
Once we diagnose this is DVT, we will not let you first go home. You need to be admitted. You need to be treated. We have the medication we are giving until you feel better. We send you home with that medication. You continue taking that medication at home until when you are close to delivery. We will not let you delivering in the same way, the same time you are taking that medication. No, because you will bleed a lot. Now, we stop the medication 24 hours before delivery. And you stop, you don't take medication. After delivery, if it's normal delivery, we restart that medication in 6 hours, if it's normal delivery. But if it's a cesarean section, 12 hours after delivery, we put you back. Now, when you put you back, we are going to work with you, taking that medication postpartum, and for 4 to 6 weeks. From then, you are free. Now, the coming pregnancy, we will not wait for you to report pain again. No. As long as you give me that story, I say, this patient is...
you start treating it.
Yes, we start now. Now that the dose we are going to give you, the medication we are used to give, is preventing dose. We put you in that single dose per day until again you finish that. Even for blood pressure, preeclampsia, we will not wait for you. No, this one you have started, but the blood pressure is good. When we wait for you to develop again preeclampsia, no,
so
we can prevent.
Yes.
So that's why it is important always to keep the information and to give to the doctor.
Yes. So does that mean every other pregnancy I get, I will be taking medication for this?
Yes, to prevent, yes.
Wow. When you say that you will stop the medication 24 hours before delivery, if I happen, giving birth happens naturally. I cannot tell I will give birth in the next few minutes. How sure are you that you're stopping it at 24 hours because I'm going to be giving birth within that period?
That is becoming a little bit tricky because you see, when you have cesarean section, is called elective cesarean section. You prepare. Now, when it comes, it's coming for natural birth. It's a little bit tricky because you can just finish taking your dose and the labor start.
Yes.
Yeah. But now we have also prevention, antidote. We call it antidote.
Okay.
For those medication, we should have it. We should not wait until we will ask you the last dose. When did you get it? Oh no, the last dose, it was 8 a.m. but around 10 labor start, and now I'm here 4 centimeters. We need to give the antidote.
So there's an antidote. So what happens if you stop, but then labor prolongs? As in, I do not give birth until maybe 12 hours later.
No, it does not matter as long. It's not that because you have stopped and everything changes.
Because it's still in your system, so you're still covered. Okay, it's very good. Is that the medication that I hear you get injections for DVT?
There are 2 types. We have Clexane, which is common. We give injection. The warfarin, is tablet, but warfarin first trimester is contraindicated for malformation. Yeah, it's even cheaper than Clexane. Yeah.
So, but either.
But now, when you are taking Clexane, when you are taking warfarin, we are not also good happy about it because it require checking routinely ENR to see what is the level we have, and we need to fix the target. Which target do you want that the result when it comes out? It should be maybe between 2 and 3. Now, when you see, now you will be forced to come hospital check lab. Now, to avoid also that, Clexane is good. Clexane, you can there's a factor 10 in coagulation breakdown. There's a factor 10 active, which we need to check, but often it's not mandatory to check, and that's why Clexane is good. Even when you do not check, it does not cause harm to the mother and the baby.
And is that the one that you mentioned is injections?
Yes, that would call Clexane, yeah.
And can you do it yourself as a mother?
Yes, but when you go home, see, in the hospital we can give you, but once we discharge you with those, we will show you how to give.
Also, you can continue doing it at home, or have someone support and do it at home. Okay, that's, because I've heard about it.
Yeah.
And I know many people really are scared because you have to keep giving yourself injections until, but the key is
it's not a big injection, it's a subcutaneous small, but psychologically you can be affected.
Yes.
But it's not injection of going deep,
Okay.
it's just a subcutaneous.
And you still
But the diabetes, they are doing insulin, they get
Oh yes.
but them they are getting for life.
Yeah.
See?
Oh well, yes.
They need
It's
to
for a
understand
period.
that.
Yeah. Yes. The sacrifice that comes with.
And it's a life-saving injection.
It's true.
Yeah.
Yes, we should keep that in mind. So once you've become pregnant, obviously there are lifestyle changes you're supposed to take on. What are the ones that you would recommend you as a pregnant woman should now change now that you're now that you're pregnant? Let me put it that way.
Yeah. When it comes about nutrition, most of the time we send them to nutritionists to have a discussion on that. We can also advise, but not much.
Okay.
It is good also to respect those people who have specialized
in that.
And you see, we will not go much out of our scope as a gynecologist obstetrician, and we can have knowledge about nutrition, but not much also. We don't go deep, but nutritionists, they can go deep. If we have a nutritionist, they can have a discussion of the patient, and out of the food we can advise, but there's also the patient who are asking about gym exercising at home. We most of the time we tell them we can exercise, but not strenuous one, too much. It is required too much also, because it can also lead to miscarriage and preterm labor. But you can still do. You can walk 15 minutes going, 15 minutes coming back. You can do some exercise at home. It's still okay, but not strenuous one, which is demanding a lot of energy.
Yes.
No, you don't have to, because you need more energy to keep more energy for you to share with the baby.
Yes.
But if you finish all in exercise, it will not help also the pregnancy. I think that is a lifestyle most of the time we advise the patient. But there's also a specific lifestyle which you give to the patient when you have preeclampsia, when you have diabetes, when you have this. Now we give lifestyle based also on your condition.
So is it something that if I choose to give birth at RFH, so I've decided to start my ANC clinics at any RFH branch, when I first come from my clinic, the very first one, will I be able to now be directed to every single person? Now, if I come to see, I see you, the OB-GYN, then will I then be given a chance to also go see a nutritionist? Is that something that is standard, that I will have someone to work with me through every...
we will not just, you come to see me, and I send you to others. No, we don't do that. What you see, as a doctor, you should be able to know the situation for your patient.
Yes.
The patient, I feel there's no any problem. How's your eating? No, I'm eating well, doc, I don't have problem. Why should I send you?
To the nutritionist.
Nutritionist. You get the point?
Yes.
But I can see, this patient has a problem. This, you see, let's say there's a patient who say, no, you are giving me medication for heartburn, but once the medication I stop, it's too much. That patient, I can't just continue giving medication for heartburn. What I need to do is, see first a nutritionist. Maybe in your food you are eating, there is a food which is stimulating too much your stomach for hyperacidity. Now, nutritionists can help you. So, no, which kind of food are you having? Give me your food you are often taking. You take this. No. This one, it can stimulate your stomach too much for acidity. You need to reduce this one, or you need to stop. But this one is going to, the nutritionist will advise on that. Because of what? Because I see my patient has a problem. Every time she comes with the same problem. Now I need to associate a nutritionist. Yes. And sometimes I can associate also physician. You see, the hypothyroidism in pregnancy. It has happened. And I need to associate also physicians or endocrinologist to associate that person. This my patient is having this, but we don't manage it. And we are having difficult to manage. What can we do? Can you come in? And we start following that patient together.
So other than the common complications that arise due to pregnancy, what are the warning signs a pregnant woman should not just let it slide because you think because you're pregnant?
You see, when you have a headache, you don't just rush. I tell my patient, don't rush and take paracetamol. Call me. And when they call me, straight away, I just think, hypertension, can you give? Please check your blood pressure. Tell me, that is normal. Good. Hey, we need to do malaria test. It can be. Now start asking, where did you go? No, I went to Kisumu for 2 days and I came back. You went there, you did not even tell me that you have gone. Sometimes I tell them you don't travel without my permission because I need to know she's going to Kisumu. There's malaria. She needs prevention.
Yes, before she
coming. You get the point? Now, if you tell me, knowing that there's malaria, I will prevent. But you have gone and come. My dear, please come to hospital. They do that for your headache. But we can do all those tests to find that just headache, just come. We give you take paracetamol. When you take paracetamol, you are okay, and we move on. Because based on changes of the pregnancy, it can lead also to headache.
Okay.
Now, advantage now to have your gynecologist, you see, we are excluding the danger things before we can allow you to do something. You get the point?
Yes.
Yeah, you can also have urine infection. It's not good in pregnancy. You have vaginal infection, which many people, they call UTI. It's not UTI. UTI and vaginal infection, they are different. Because the urine is coming another side and the vaginal problem is another side. Yes, infection in pregnancy is not good. You need to know that pregnancy is a foreign body, and the body of a woman does not love to carry pregnancy because it's a foreign body. Now, what happens is that when you become pregnant, those hormones, they are very important. They reduce your immunity. You get, Now, when infection comes in, is sensitizing your immunity to pick up. What is going to happen? They chase out your pregnancy. That's how infection can lead to miscarriage or preterm labor. You get the point? Now, infection is not good in pregnancy.
Yes.
We need to avoid. Once you see discharge, itching, smelling, whatever, you need to rush to the hospital. You can also see when you are seated, water coming to your legs, this and that. That is a rupture of the premature rupture of the membrane, and you need to rush for us to identify. It's not your urine, maybe. It might be your urine. You get the point?
It could be
urine.
No, I'm asking, could it really be urine?
Yes, we need to identify that's why.
At very first trimester.
Yes.
There's no pressure. Is there pressure?
No, there's no pressure. It can. That's what we call differential diagnosis. You see, when you have an issue, you don't just conclude that is what has ruptured. No. You need to have a differential diagnosis in you. How can I examine my patient to make sure it's not urine? Because you can consider urine that no. She delayed to go to the toilet, she was full, and she
just passed, yes.
You get the point? Now, when it's passing, you also know she has come, it is a rupture of the membrane. You consider that way. But when it was urine, you need to make difference between the two. That's why examination is important. You need to examine, you need to use a speculum to see. There's a Valsalva maneuver we do to see if there's a fluid coming from the cervix, there's a pulling, all those things. That to give us a no, it was not urine, she's draining. Like, you get even the color, even the smell, all those things. Now, those are you should not bleed in pregnancy. Once you are pregnant, once you start bleeding, we need to find out why. Because you can bleed like that, and that is the beginning of your miscarriage or preterm labor.
So how will I differentiate? Because we hear that you will experience spotting. Some experience spotting. Is spotting normal during pregnancy?
It's not normal.
It is not.
It's not. You should not spot. But there's some period of pregnancy after fertilization and the implantation is taking place. You can have some spot. But I will not tell my patient, if you see some spot, just observe. You come to me. I examine. We do some tests like a scan, all those things. We exclude other things. Yes.
Okay. So you also mentioned that obviously visiting the clinic is very important. If I am not able to visit the clinic every single month, is it okay to go every other month?
When you are not visiting every month, you skip some month.
I skip a month.
And you come and
because
see.
Some decide I will not go this month, I will just go next month.
Yeah, I don't, you see, before, the number of visits was limited to 4.
Yes.
But those pregnancies had a lot of issues. Huh? You see, don't expect me to do miracle. It's a hospital. If you come on time, let's see, often I'm in contact with you, we can identify the issue earlier and stop. But more you take time. You'll come and it will be too late, and we just tell you, madam, you have lost the baby. That's it. Once that word has come out, there's no way to change it.
There's nothing to change.
But more, you see, being closer to the doctor is better than staying far. Yes.
That is true.
Because we can identify issues. You see, like I've told you about UTI asymptomatic. I'm doing, you don't have to pay nothing, but I'm doing leukocyte 3+ or 4+. This is infection. I give you antibiotic. But when you come the 2nd or 3rd month, is when it has gone to the kidney, this and that. Maybe there's threatened miscarriage or threatened abortion, all those kind.
Something that could have been avoided.
Yes.
So as we conclude, why we're usually told that a mother has to have your emotional and mental well-being should make sure that you are at a stable point. Why would you say that is key for a pregnant woman?
Yeah, it's key. You see, pregnant woman, she has gone through modification during pregnancy, like I said, about all the organ.
Yes.
And there are some behaviors due to those hormones they are having, and we should be able to understand them. You should not consider pregnant woman as before she was pregnant.
Yes.
We need to have a different consideration. They need our support. The support you give is not just giving money, giving food, but your presence is important. She needs to see somebody's beside and somebody's considering a status. You need to understand them, even when they talk to you, even when they act, some actions they are doing, you need to understand them. Another way, you need to reach in their level of doing whatever they are doing, to consider them that way. Means that you need to avoid the actions. Let's say you have a pregnant woman in the house and you are beating that woman because I told you this, you have forgotten, you slap. No. You need to understand those modifications. I've told you, the brain increase the volume. She can become forgetful, and she can become nervous. You see those kind of things. We need to be able. That's why we encourage the men to bring them to our clinic. Because when we are talking, man will understand. the woman here, it's not the
going through
woman
that.
which I met before pregnancy. This
This
is
is
another woman. I sometimes
a
I make
different
them,
wife.
Yes, I met them here and a pregnant woman is a modified woman. It's not it's not the normal woman we know.
You know.
She's modified. It means that if she's modified, we need to be very careful in our action. It helps.
Yes.
As long as she discovered that I'm loved.
Yes.
And people they are around me. I've met a patient. She has delivered. She cried in my office. And you know what she was telling me? No, my husband is not in my side. That affected a lot. But anytime she needs you, you are there. You are able to help. She's a big pregnant. She want to put the shoes. You come, you help. You put the shoes for her.
For her, yes.
You get the point? She feel that, no, they are taking care of me. She want to do something. You can be there. No. Can I help you? Are you able to do alone? She wanted to sit. Can you make sure that chair is good? You see, that is some simple things.
Yes.
But she feel better. She tells herself, no, there's somebody who's beside me is helping.
That is true.
But she's pregnant, abandoned. Everything she does alone.
It affects her.
Yeah, it brings stress. She can become more nervous like before. Psychosis, depression takes place, all those things. And that complicates the life of that woman. Because she needs to start being given some medication, this and that.
Yes.
And the more she takes, you see, you wake up in the morning, you have plenty of medication in your hand. You need to.
Yes.
It affects.
True.
Yeah. Now, every man who has a woman who's pregnant, you need to be there.
Present.
Avail yourself for that woman. She needs that.
Yes.
Yeah.
That is true. Because I think some of the women who experience postpartum depression could have also have been a result of this.
Yes, most
during their pregnancy.
Yeah.
So this can also can this affect your relationship with your baby? Might you be
Yes, because when you
having
have a
problems to
depression,
bond? Yes.
depression, psychosis, what are you going to do for that baby? So can take the baby throw out.
And it started back when you were pregnant.
Yes.
Oh. All right. Yeah. So, Doc, as we conclude, perhaps you can share something very key to our pregnant women, something that they should keep in mind during this 9-month journey that is ahead of them.
What I can tell them is that success delivery and good outcome is antenatal clinic is the key. Don't neglect antenatal clinic. Second thing, consider your doctor like your own heart. When you have your own heart, you will not keep some things you don't want to know yourself. What you know it. That is your doctor. Make sure that even when you have social issue, open yourself to the doctor who will assist you. We advise. We are even reconciling some couples. We call the man, we make him understand. You see, like when I'm telling you about modification in the woman, the changes, the which are taking place.
Yes.
Some men, they don't know. They don't know. They are acting by ignorance. But if I call him, he comes. I've done that before. Yeah. Where is your husband? Oh, doc. I'm not going to see you now. Just tell me. Oh, doc, there's a problem. Leave me there now. Man, how are you? I'm okay, doc. Where are you, man? I'm this and that. No. We are waiting for you. Come, I want to see you. The man is there.
Yes.
You get that?
Yes.
I talk to them and I'm seeing them going home together. That's good.
It is.
You see, yeah?
Yes.
You have resolved the problem. Then you are just focused. Headache, paracetamol.
Here's your medication.
Yes, yes, yeah. But you should be open to your doctor.
Doctor, yeah.
And tell your doctor everything. We are not just the doctors of medication or operations. We can also help in social way. Because if my patient socially is stable, whatever I will give to my patient, it will succeed. Whatever I tell my patient should be able to do it. But socially is disturbed. You are sending that patient home where they are waiting. There's whole home.
Yeah.
How are you going to resolve that? She just reach home. She will not take even your medication.
Yeah, true.
You see, huh?
Yeah.
Now we need to. I think those two things, they are very important.
Thank you so much.
Thank you.
So that is the conclusion for today's episode. Doc, thank you so much for availing yourself. I believe you are stationed at Kiambu, the RFH Kiambu Road. Is that
I'm a
right?
resident gynecologist for RFH. RFH has different branches.
Yes.
And I'm moving to all the branches.
All right.
But I'm based on the main hospital, but that does not limit me to go to other
Any
branches.
other branch.
Yes. And my schedule is so full because I'm moving. Like now I'm going to Sokimau branch where I have a clinic this afternoon. Yeah.
So what if a viewer wants to come and see you specifically? How will they go about it if I want to see Dr. Mashala?
Yes, you want to see me, you will not see me out of RFH. That's one.
Yeah, okay. Not outside.
Because I'm a resident, is RFH or nothing.
Yes.
I'm for RFH.
Yes.
Now, any branch of RFH you can see me. Monday, you can see me in Ruai, specialist.
Yes.
Tuesday, you can see me in Ruiru, RFH. On Wednesday, I'm in the main hospital specialist in Ruai.
Right, yes.
Thursday, I'm in Kiambu from 9 to 12. And the afternoon of the same Thursday, I'll be in Sokimau from 2 to 5. Friday, I'm in the main hospital, Ruai specialist, from 9 to 3. And Saturday, I'm in Imaramol from 8. In Imaramol, we have RFH. We have 8 up to 10. And from 10 to 12 or to 1, I'm in Nyayo RFH. That is Sunday, I don't do clinic, but I still cover RFH because I said I'm RFH.
Oh, nothing.
Means that if in case of emergency, Jonathan will be there. But I'm not coming to Kiambu because of that clinic. Even in emergency, let's say I'm leaving now, but they have emergency after me, they used to call me, I come back. And I try to manage my clinic, how I can help, because we cover 24 hours RFH.
Yes.
And at night, there's emergency, we come. I have my patient for operation, I plan when to do them, delivery, when to do. Yeah. What is very important with me, my patient, all my patients, if I've seen you, means you should have my number.
Sure.
And I pick calls.
Oh, that's good to know. That is good to know.
I pick calls more than others.
That is at least your patients will let you know that they're traveling
I
before
pick
they go
calls,
to Kisumu.
But sometimes, yeah, that's good. But sometimes, you see, you
Life
can be
happens.
called all night, by
Yes.
the patient. You don't sleep, but I appreciate that.
Yes.
At least I'm in contact with them to know what is happening.
Yes, what's
because you can't call me at 2 because you want to play game with me. We are adults and are responsible people.
Yes.
When my patient calls me at 9, I'm telling myself, this is serious issue.
Yes.
I need to pick that call. Yeah.
All right, you had it here first. That is the end of today's topic. It was very informative. We enjoyed it. As he has mentioned, if you want to see him, you can go to any of the RFH branches. So please remember to leave us a comment, like the episode. Don't forget to share.
One
thing.
small thing. I can even give my number.
Oh,
0733313471. 0733313471. Dr. Jonathan. Call me anytime. We talk.
Thank you so much, Doc. So until next time, it's been a pleasure. Bye-bye.
Right. Thank you.